Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge topics to the Staten Island and tri-state community. Today, we're going to be talking about infectious disease, or different kinds of infections. And I have two truly wonderful guests. First, I'm going to introduce Dr. Crystal Delp. She's the Chief Resident in Internal Medicine at Richmond University Medical Center. Thank you for coming.
Thank you for having me.
And Dr. Jessie Saverimuttu, who's the Head of Infectious Disease and Head of Quality Assurance, maybe not exactly, but one of the infectious disease specialists at Richmond University Medical Center. So welcome, everyone. So tell us what infectious disease is.
First and foremost, thank you, Dr. Perel, for having us here. Yes, so the question is, who is an infectious disease specialist? Is that what is the question? Yeah, an infectious disease specialist is someone who deals with infections. So what do we mean by infections? Infections can be an array of diseases caused by a vast array of microbes. They can be bacteria, they can be viruses, they can be fungus, they can be parasites. So any infection that's caused by these would be dealt with by an infectious disease specialist.
So what's the training of someone who's an infectious disease specialist?
Yes. So I'm an adult infectious disease specialist, so I can speak for the training for the Adult Infectious Disease Fellowship. First, we have to go through internal medicine, and that's a 3-year residency program, after which there is a 2-year fellowship. Most of the time, it's a clinician track which is followed, and that is 2 years. There are 3-year tracks, but that is for research. So for clinical purposes, it's a 2-year track, and you complete your fellowship in 2 years.
And Crystal, tell us a little bit. You're a chief resident in internal medicine. So what is internal medicine?
So internal medicine is the dealing with, we deal with adults, as Dr. Jessie said, she deals with adults infectious. So anyone over the age of 18, just general complaints that they have, like, when you go see your primary care doctor, that's kind of what we do, but inside the hospital. So we're kind of like the person who coordinates the whole care for the patient while they're there for whatever reason they may be there.
And you're exposed to a lot of different fields of medicine. So maybe you can tell everybody what kind of fields you're involved in.
Yeah, we have a lot of different subspecialties within internal medicine. Your gastroenterologist, your cardiologist, infectious disease, rheumatology, nephrology, pulmonology. You have another step of, so for the sicker patients, critical care, all of that starts out with internal medicine, and then you kind of contact whoever you may need help with whatever the patient's there for.
So we're talking about infectious disease today. And is it different between, so I'll ask Dr. Jessie about things that happen as an outpatient or in the community. You're more involved with what goes on at the hospital. So tell us, are you exposed to a lot of training in infectious disease?
Yeah, I don't think there's a day that goes by in my residency that we don't see some patient with some infectious disease, whether or not that's the reason why they came to the hospital in the first place. We've seen everything from like the common cold that people come in with, COVID obviously, to very not as common things. We've seen Creutzfeldt-Jakob disease, which is very rare. We saw one last year, so that's like a prion disease. It's a different type of infectious disease. So we definitely get a lot of exposure to infectious disease, whether or not we're specifically on that rotation while we're in the hospital.
So Crystal mentioned COVID.
Yes.
So we're a couple of years past the pandemic, the epicenter, the magnitude of the pandemic. Tell us a little bit about what's going on with COVID now.
I'm glad to say that the numbers are quite low. And it's maintaining that way, at least in New York City. So, but there are sporadic cases that we do see. It's not anywhere near what we saw during the pandemic.
Super. And what are your recommendations about vaccines?
CDC recommends that everybody, get 1 dose of the newest vaccine, which actually targets the XBB lineage of the Omicron variant.
So tell us make that a little simple for us.
Yeah, it is one of the variants which was considered virulent, and they targeted the mRNA vaccines to combat that was prevalent at that time. So this is like 2023 to 2024, and that is where it is right now. So we do not have anything coming beyond that. So that was the strain at which we stopped.
So the one vaccine should be after what? After when? So I want everybody that we're seeing to really get a little bit of a feel of when and how. If they got the vaccine a year ago, would that be enough? 2
Yes,
years ago?
correct.
So
This
after what time?
the latest vaccine was last year. So anyone who has not had any series of vaccines, they can just take one dose of this vaccine and they should be good.
After, I'm sorry, I know what you
Any
mean.
time is fine.
Anytime
It's
after
fine, but just that,
2023?
yeah, yes, just that one dose.
Okay.
And there is nothing beyond that yet, and hopefully there won't be. It's not like every year, like the flu vaccine that you have to keep taking.
Absolutely.
So far, there is nothing, yes.
So let's talk about people who go to the hospital.
Yes.
And that's your expertise. Again, you see a lot of people in the hospital, Crystal and Dr. Jessie. So tell us the difference if someone gets sick at home versus someone who gets sick in the hospital, who gets an infection.
Right.
Is there a difference in how they do and how we treat them?
Yes. So it depends. Now, if we take it that the patient has an infection, and that is the reason the patient is coming into the hospital, that is a community-acquired or community-onset infection. That's one category. But if we are talking about a hospital-acquired infection, it ordinarily means that, say, the patient comes with a stroke, and then while being treated for the stroke in the hospital, the patient acquires a hospital infection. So what are these hospital infections that are commonly acquired by patients? Of course, respiratory infections can happen because, the stroke patient can be next to a patient with respiratory infection, and this patient can acquire it that way. Yes, simple thing, pneumonia, could be viral, acquisition. But what is acquired in the hospital is mostly from procedures, not that procedures are leading to patients getting infections all the time, but for instance, if a patient requires a Foley catheter.
Tell us what that is. That's some kind of an indwelling catheter.
Yes, a patient cannot pass urine, or we have to monitor the patient's urine output in a critical care setting. The patient has to have this catheter. And this catheter, if it is left in for a prolonged period of time, it being a foreign material to the body, that can get infected because bacteria pass along the foreign material and infect the bladder. So patient can get a bladder infection from the catheter. Mm-hmm. The other way is like when they're critical, they require lines for multiple infusions, intravenous lines. And just a simple intravenous line in the periphery is not adequate to give several infusions at the same time. And especially if the blood pressure is low and the patient is critical, they require lines that go in the neck. And if it is so urgent that the patient could crash, they put it in the groin, and groin area obviously is not the cleanest area. So having this line, especially if it's put emergently, it has a high potential to getting infected because, yet again, this is a foreign material to the body. So that is another example of a hospital-acquired infection.
So, Crystal, our goal in the hospital, and when patients come in, there's sometimes the patients want to leave usually faster than we even want them to leave. But sometimes people are surprised that we want them to leave so quickly. Whether someone has had a stroke, in my case as a neurologist, or any of the conditions that you think of. And sometimes people, even with pneumonia, come to the emergency room, are treated with antibiotics and go home, or even at their primary care physician. How do you, as a resident, what kind of things do you do to prevent infections? People were afraid to go to the hospital during the COVID-19 pandemic, and they were afraid of getting sick, and many times rightly so. What do we do right now? And it might be as simple as washing your hands, but tell us, how could everybody who comes to the hospital be less afraid of getting an infection in the hospital?
Well, as you mentioned, the biggest thing is hand washing. Just whenever, like, for example, I go in to see a patient, wash my hands before entering the room. We use gloves when we examine the patient. Wash your hands when you're exiting the room. Like, that's one of the biggest things to do to decrease transmission of any type of infectious agent. Also, there are some things that are more transmissible for the different ways, like COVID. We go in wearing the masks to make sure, we're not picking it up and then transmitting it to somebody else before we know we even have it. There's other diseases that we wear gowns, to make sure, again, all of it making sure that whatever that patient has stays in that room, so that way we don't transmit it to other people. But one of the biggest things is just, washing your hands as much, or whenever there's an encounter with somebody new.
And try to get people home as soon as possible.
Yes.
Yes.
Because the less time you spend in a place where there are sick people, the less likely. And taking out IVs quickly.
Yes.
And catheters quickly. And all
yes.
kinds of any foreign items as quickly as you can. So that all really helps with it. Do you think over time, and I know one of your other hats, including to infectious disease, you're so wonderful with quality assurance. And people out there probably don't know what quality assurance is other than hearing the word.
Yes.
What does that actually mean?
So actually, we call it quality improvement or quality assurance. Either one is okay. Yeah. So being in a hospital setting or in a healthcare setting, we have to ensure that the patients are safe and patients have a good experience, and they're treated in such a manner that they feel good and that they feel they have been taken the best of care there and they go home happy. So how can we assure that all this is done? It's only through making sure the quality of care that is rendered to the patients is the best and the highest. So there are several angles through which we can achieve the greatest quality of care. And one of the greatest areas where we can do this is controlling hospital-acquired infections. Actually, Centers for Medicaid, Medicare Services categorizes about 22% of their rating of hospitals on this control of infections. So what are these infections that we can prevent from patients getting in the hospital? Of course, we spoke about the central line associated bloodstream infections, Foley catheter associated urinary tract infections, Clostridioides difficile infection, which comes on with excessive use of antibiotics.
So people have heard of that as C. diff.
Yes, we have heard of that as C. diff, yes. And the other one is MRSA bacteremia, which means methicillin-resistant Staphylococcus aureus bacteremia. And the patients do not come with this bacteremia. Bacteremia means the bacteria in the blood. They don't come with that to the hospital, but because the lines are inserted, they get it into the blood.
That's almost a skin infection that somehow
gets in. It can go
in.
into the blood, and that's fairly dangerous. So these 4 big categories. And of course, surgical site infections are also categorized in that. So, and certain other obstetrical, surgical infections as well. So this is one big bucket. So what are the other buckets that are there in terms of quality improvement? Patients with COPD, that is the lung disease, patients who have myocardial infarction
or heart attacks,
patients who have congestive heart failure, the heart fails, and patients who have pneumonia. These patients, once you treat them, they should not go to the community and come back within 30 days. That means something was not done appropriately or they were not given the appropriate follow-up. So they have to be told, go back to your primary care, go to your cardiologist, make sure if your weight is going up, you inform someone. So those parameters have to be looked into. So that is another angle of care in quality improvement.
So quality improvement is basically giving the best care you can in the hospital.
Yes.
Trying to help improve anything the nurses do, the residents do, the doctors do.
It's a team effort.
And then just trying to hope and hope people do well long term.
Yes, and hope that the patients themselves understand the importance of outpatient follow-up, keeping up with their appointments, taking their medications regularly, making sure that if they do not have a medication, contact their primary or the subspecialist and get the appropriate care as outpatient as well, because it's important. That is how they will not have to come back to the hospital.
We're all tremendous patient advocates. So just a couple of examples I'm curious about with you. If a person comes into the hospital, is there anything they could do to reduce the risk of infection for themselves or a complication for themselves? Have you had patients ask you to wash your hands? I have.
Yes.
You walk into a room, they ask, have you washed your hands? And again, that's something that's important for someone to be able to say that. And the relationship between the patient, the person, and their doctor or their nurse really has to be open enough in the hospital to be able to say that without someone being rude or
Yes.
giving some kind of a remark back. But how about the patient themselves? Should they be washing their hands? Should they be trying to avoid touching things? Should they have less visitors? I mean, there was a big deal many years ago, everybody got flowers. Now, very few people get flowers in the hospital because everybody's worried about all kinds of things. Is there anything you could do to protect yourself if you're going in there? Because I think so many times as physicians, we go into a hospital and see a relative who's ill, and we sort of see little things that no one else really sees. And we say, well, let's do this, let's do that. Why do they need the intravenous? Why do they need the Foley catheter? So maybe, and again, a sort of long-winded question, but if you had a lot of experience with patients or advocated for patients and happy when they ask, when can mom have this catheter taken out?
Correct.
Do I really need the intravenous in? And to really tell both the patient and the doctors that it's not wrong for you to advocate for yourself and talk about it.
Correct.
So maybe just any thoughts about that?
It's good to empower the patients. And in order to empower, they should also be given that knowledge. So, for instance, if a patient comes in, the patient should be told what are we treating that patient for? And what are we anticipating? What is it that is going to happen to that patient today? So we are going to get you an MRI today. So the patient should be told. So once that is done, and if the patient is aware, I'm having this diagnosis, at least that is the presumptive diagnosis, and I'm going to have an MRI done to confirm it, or any other test done to confirm it. Or if I'm told you have bacteria in your blood, and we need to do another blood culture just to be sure that that bacteria has cleared with the appropriate antibiotic. So having the knowledge of that, if there is anything that is done beyond that which may seem to the patient not in line with what they have been told, they have to be empowered to ask the question. So now if someone comes to put an IV line while there is already an IV line, they could ask, I have this one, why are you putting a new one? So if they say, oh, this has been there for 72 hours, we want to remove it, then that gives the answer. Oh, we need an extra line, then you have to ask, why is it that you need this extra line? And yes.
Maybe, Crystal, you could tell me as a resident, you spend a lot more time with the patients during the day than either Dr. Jessie or myself. We go in there, we make an assessment, we order some tests, we might look at the chart on the electronic medical record. But the resident, and we're going to actually be talking about this a little bit later, is the one who spends all day. That's what the word resident means. The term intern used to mean you're interned at the hospital. Resident, you lived at the hospital. But now we've come past those days where, thank goodness, residents could actually go home at night and get a good night's sleep. But being in the hospital so many more hours and being with the patient so much more and getting to know them, especially as the junior residents who were taking care of a certain number of patients. So tell us a little bit about what patients ask of you guys and really what your relationship is with them with regard to this.
I think the biggest thing is just communication with the patient and the family, if the family wants it, because they're in this situation, they're sick, they don't know what's going on. They're more likely to be a little bit more anxious if they don't know they're going for tests, they're not getting results. They see a big sign on the door and people coming in with masks and they don't know why. So the biggest thing is just communicating with the patient and being willing to sit with them and answer any questions that they or their family might have, until, even if it's the same questions over and over again, multiple shifts, multiple people, until they understand what's going on. Because until they understand what's going on and are able to actively participate in the treatment that we're giving them, they're not going to get better. They need to be able to participate with us to, for everything to go as smoothly as possible, because we have to work as a team. It's not us doing something to them for them to get better. It's us working with the patient for the patient to get better. So if they're not understanding what's happening, or why they're going for an MRI, or why they're getting an antibiotic, or why they might need long-term antibiotics, for example, all of that can lead to persistent infections or repeated infections, or problems coming back over and over again, because they have to be understanding and willing to participate in that as well.
And I think it's amazing that we have this device, this little tablet where you can speak any language. You'll have an interpreter, any language.
Yes.
They even have they have someone who could sign on it. I didn't realize that sign language is one of the languages. Right. I think it's amazing that we're able to bring that to our patients. Let's talk about antibiotics. Too many people, and I won't even say anybody in this room that we're in, have a Z-Pack around just in case. And so tell us a little bit about antibiotics, and maybe just try, if you could put it even together with, like, are people, or if you watch television, which is television, but if you watch and look about these superbugs that people get frightened of and say that there's really not many new antibiotics coming out, and we're going to all be overtaken by terrible germ superbugs, as you mentioned a little bit before. Tell us a little bit about antibiotic use and when we should use it and when we shouldn't use it.
Yes. So antibiotics should be used only when there is confirmed bacterial infection.
It doesn't work for viruses.
It does not work for viruses.
Most viruses, right.
The antibiotics don't work for viruses,
okay.
period.
Okay.
Because there are antiviral agents
Antiviral.
which have a separate, they are a separate class by themselves.
Right.
And they do not work on fungus.
Right.
So fungus have a separate class of antifungal agents. So antibiotics are only for bacteria. So if there is no bacterial infection, there is no indication to use antibiotics, period. So for instance, if a patient comes in, they go to the outpatient setting, they're sneezing, they're coughing a little bit, low-grade fever, not feeling too well, stuffy nose. And they go in and they see their primary care, and the primary care says, I don't think you need an antibiotic, just take a lot of fluids, and if you have fever, maybe just take acetaminophen. And over a period of a few days, you should get over this. Some patients may not be happy because they would think, oh, I was sent with nothing. I would have preferred taking an antibiotic. Such patients do not need, because it's most likely than not, it's a viral infection. So overuse of antibiotics when there is no indication leads to the ordinary bacteria becoming resistant to the antibiotics. And this resistance leads to what is called the superbugs. And there are plenty of superbugs around, but there aren't enough antibiotics to combat these superbugs. So if we keep using antibiotics and overusing them, then it's going to be a problem because we won't be able to treat.
So we shouldn't be taking antibiotics unless there's an indication for it.
Unless there is a clear indication that what you feel is really caused by a bacteria.
And especially if most of the family has the same illness as you do,
it's most likely a viral
most likely
infection.
viral.
Yes, and it will pass. But bear in mind, of course, some people can get a secondary bacterial infection, especially if their immune system is weak. Such patients may need a little help with antibiotics, but not as soon as they start a sneezing and a coughing and a stuffy nose. You don't need to
So if
take
you have
that.
a viral infection, do antibiotics get you better faster?
No, absolutely not.
So even all the anecdotes that people talk about, and say, I took those antibiotics and the next morning I was better, they probably would have been better without it.
Even without it, yes.
Placebo effect.
Yes,
Absolutely. Tell me a little bit about age of the patient.
yes.
So you said you're an adult infectious disease specialist, and internal medicine is really over the age of 18. When you see someone who's 18 or 19, 20, a young teenager or someone in their 20s have an infection, is that different than if someone who's in their 80s or 90s?
Yes. Crystal, you want to answer that?
Yeah, their activities are different. What they're doing is different. The things that you'll ask them about is different. You're a younger person, you're going to ask more about sexual history, drug use, for example, things like that you don't necessarily think of for an 80, 90-year-old. An 80, 90-year-old, even the active ones are more at home with family, things like that. And then if they're that 80, 90, some of them are in nursing homes, which is like a whole different category that you have to look at. So it really varies depending on the patient's age and just, their recreational activity, really.
So here we are talking of a spectrum, right? The young people have a robust, hopefully, unless they have disorders which lead to immunosuppression, by and large, the young people have a robust immune system. But they acquire infections which can lead to immunosuppression. That's one end of the spectrum. The other end is the elderly, they are not exposed, but they still are vulnerable only because of immune senescence. And that is it's an aging process of the immune system, and that prevents them from mounting an immune response, even if they're exposed to the mildest dose of an infectious agent.
Absolutely. And if you think about it, if a 20-year-old person comes to your office and they have pneumonia, they'll mostly go home with the bacterial infection. They'll go home with some oral antibiotics. If a 90-year-old person comes in with breathing problems and pneumonia, they'll wind up at the hospital, and their prognosis is very guarded, we'll say, in what could happen. So tell us about new things in infectious disease. As a neurologist, there's always new things going on. And I think some of the interesting that when I go on rounds and I listen to you at all the talks that you give and all the meetings we are, the names of the infections become longer and longer and more complicated. And the names of the antibiotics also become longer and longer and more complicated. Tell us a little bit about what new things, and are there any things we could treat that we weren't able to treat before, or more?
So times have changed, and what was being treated with penicillin, the same bacteria have again become superbugs. So that means they are resistant to the simple penicillins. So when you ask, is there anything new, I think what is foremost new in this whole area of infectious diseases is the bacteria that have become resistant and more resistant and more resistant. One of them is not a bacteria, but it is a fungus, which is in the limelight in the recent past, and that is called Candida auris. That is a yeast. So Candida is a yeast. Candida albicans is the commonest yeast that people come across, and you get thrush in your mouth. When people take antibiotics, they do get vaginal thrush and so on. That's the simplest form. But the Candida auris is the newer variant, which is highly resistant to antifungal agents. So globally, it's becoming a threat. So that is something new. Yes. And if we talk more about the common diseases, think about tuberculosis. It's making a resurgence now. And what is scary about that is it's becoming multi-drug resistant. So what was thought to be under control is now rearing its ugly head, and it could become, quite like a wildfire. People could catch tuberculosis, again with multi-drug resistance.
So we can never put our guard down.
You should not be putting your guard down.
And we've heard about things like the avian flu recently, so there's things that are coming on more and more recently.
Avian flu, thank God, is with the dairy. Yeah. And there was only one human being in Texas, in the US, who got that. So hopefully it doesn't jump into human beings and become an epidemic here.
Let's hope it doesn't. And I want to say thank you to you guys. Our half hour is over. I want to thank you, such wonderful guests, to be here and educate all of our people, all of our viewers about infectious diseases, how to prevent them, and how to stay safe. So have a wonderful evening. Good night.